Good morning, good evening, good afternoon, wherever you are. Welcome to another intensivecarehotline.com live stream and Intensive Care at Home live stream, emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel and I'm the host of the show. So thank you so much for joining. I also want to welcome all the viewers that are watching this on replay. Also want to welcome the viewers that have joined already or are going to join live here. What makes me qualified to host a show like this, emergency questions and answers for families in ICU and intensive care at home? I am a critical care nurse by background, having worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've also been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com, and you can verify it on our intensivecarehotline.com podcast section, where we have done plenty of client interviews that verify how we have helped them to save their loved one's life in intensive care, simply with our consulting, with our advocacy, with our intensive care insights that we simply have as intensive care professionals, and also obviously have a passion for advocacy, making sure our clients make informed decisions, have peace of mind, control, power and influence, making sure their loved ones get best care and treatment always. I'm also the managing director of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also home TPN, home IV, home IV infusions, IV antibiotics, but also home non-invasive ventilation such as CPAP, BiPAP, cough assist management at home, also tracheostomy care at home without ventilation, also ventilation weaning at home, PEEK line, Hickman's line, central line, as well as port management at home. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS provider, TAC in Victoria, NIISQ in Queensland, as well as DVA all around the country. And we're also taking on private clients, of course. Now, with Intensive Care at Home, we're sending our critical care nurses into the home up to 24 hours a day. We have a highly skilled critical care nursing workforce, and we're employing hundreds of years of critical care nursing experience combined in the community, and that enables us to safely look after the most acute clients in the community in Australia. Now, without further ado, let's look at the questions that have come in during the week, questions, comments that have come in during the week that I'm going to look at today. If you have any questions in the meantime, send them into the chat pad or connect with me live on the StreamYard link here. I have posted the StreamYard link into the chat pad. Now also, if you like the work that I'm doing here, if you think we're doing good work here, like the video, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the notification bell, comment below, let me know what content you want me to create, what questions you have, what insights you have from these videos, and most of all, share the videos with anyone that can benefit from these videos who has a loved one critically ill in intensive care. So let's just start with some comments that have come in during the week. There was one comment from a subscriber on YouTube Live from Mama Tried 925 who says, I've been watching your videos for years, and I thank you from the bottom of my heart for your genuine videos. They are truly life-changing. Well, thank you so much for that comment, Mama Tried 925. Look, my content here is absolutely user-driven. There's no fake videos. Everything that I'm posting here is driven by you who has a loved one in intensive care. I rely on the questions that are coming from each and every one of you so that I can create content that is relevant for everyone that has a family member in intensive care. So I welcome the comments, of course. Thank you so much. Now, let's go to some other questions that have come in during the week. Just gotta give me 1 minute. I'm jumping from sort of comment to comment. One question that's come in this week was whether low sodium can cause high CO2. Can low sodium cause high CO2 or carbon dioxide? So let's look at that. So, because one of our clients actually has their mum in intensive care and she can't come off the ventilator with a breathing tube, even though she's off sedation and has been off sedation for a long time now, but she's not strong enough to pass any spontaneous breathing trials. She's still in an ACV mode, which is a controlled ventilation mode, and every time they're trying to reduce the mandatory breathing rate that's coming from the ventilator, she's failing, and she's becoming hypercapnic. Hypercapnia means retention of CO2, retention of carbon dioxide, and that makes patients drowsy. For anyone that's watching this who might have sleep apnea, you know what I'm talking about, right? And that is also what I advise the client, that they need to rule out whether his mum has a high CO2, whether his mum has sleep apnea. Okay, so let's look at the question. Can low sodium cause high CO2? Low sodium, which is also known as hyponatremia, doesn't directly cause high CO2 or carbon dioxide, also known as hypercapnia, but they can sometimes be related through underlying conditions or as part of a complex clinical picture. Here is how they can be connected. Respiratory issues leading to CO2 retention. High CO2 elevated bicarbonate or pCO2 on blood tests usually indicates respiratory failure or hypoventilation, which means underventilation. Conditions like chronic obstructive pulmonary disease, COPD, neuromuscular weakness or sedation can cause hypoventilation and CO2 retention, right? And that is probably what we're dealing with our client here. If someone with these conditions develops fluid overload or syndrome of inappropriate antidiuretic hormone secretions, SIADH, they can also develop low sodium. And yes, hi, Helene, nice to have you on the show. Thank you. So, SIADH, syndrome of inappropriate antidiuretic hormone secretion. SIADH causes the body to retain water, diluting sodium levels. It's sometimes triggered by lung diseases, brain injuries, or certain medications, which can also contribute to CO2 retention, i.e., via reduced respiratory drive. So often the body compensates, and there are some compensatory mechanisms. The body uses bicarbonate, a form of CO2 in the blood, to buffer the acids. In metabolic alkalosis, which can happen with vomiting, diuretics, or dehydration, because you're vomiting out acids, the kidneys retain bicarbonate and CO2 can rise. If someone has hyponatremia and metabolic alkalosis, you may see elevated CO2 bicarbonate on labs, but this is not a direct cause and effect relationship. In summary, low sodium doesn't cause high CO2, but both can be signs of serious underlying issues like lung failure, brain injury, SIADH, or renal dysfunction. always interpret these values in the context of arterial blood gases, clinical status, and organ function. So, you know, the biggest challenge for families in intensive care is always that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what this is happening in this situation, right, with our client, who doesn't really know what they're dealing with. Now, having said all of that, the ICU is actually doing all the right things from what we've seen. We've got access to the medical records. They've done all the screening. They've done all the tests. You know, they've done CT scan of the brain, MRI scan of the brain, EEG. They've stopped all sedatives. They stopped all opiates for days. Kidneys are working, liver is working. And they've even done a lumbar puncture, you know, to rule out encephalitis, meningitis, you know, anything that would neurologically potentially hold this patient back. They couldn't find anything. So it's a bit of a mystery that she's failing, that his mom is failing all spontaneous breathing trials. But there's probably two reasons for that, or one out of two reasons, or potentially a combination of both. One would be that the patient is simply deconditioned, has weak breathing muscles after 2 weeks in ICU and after basically being immobile for 2 weeks and lying in bed. That's one reason. The other reason might simply be that she hasn't been diagnosed with sleep apnea just as yet, and that it's potentially a new diagnosis, right? A lot of patients that have sleep apnea, they report symptoms like they feel drowsy, they feel sleep deprived, they feel tired. And the minute you put them on a CPAP or a BiPAP overnight and they can blow off the CO2, they feel like they had a good night's sleep, because simply they can blow off the CO2 and they can feel recuperated after a good night's sleep. CO2 makes patients drowsy. And like I said, anyone that's got sleep apnea would know what I'm talking about here. So next, this is more the question that we had earlier in the week from our client that we're currently working with. And he said, my mom is intubated with a size 6 breathing tube with a cuff. I was told it's not the standard for adults. Given this, does it affect how she's intubated? She's scared of the tracheostomy surgery, which is what the ICU is suggesting. She's hoping if the vocal cord injury can heal, why she has the tube still in. So, yes, a size 6 breathing tube for an adult is unusual. The size 6 is usually the smallest size for an adult, and it's the biggest size for pediatrics, right? So it's sort of somewhere in the middle. The reason this particular client has a size 6 breathing tube is simply she's got airway swelling, which means, you know, her airway is swollen. That's one of the reasons she can't be extubated. On top of that, she's simply failing spontaneous breathing trials. But airway swelling doesn't necessarily stop patients from passing spontaneous breathing trials. It might just make it more difficult. If patients have airway swelling, you know, it also means you can't take out the breathing tube, because the breathing tube simply would not bypass the trachea, right, because of the swelling, and you could damage the stricture, right? So what to do when there's airway swelling? Well, first off, give some adrenaline nebulizers, and secondly, give some steroids to reduce the swelling. Now, all of that had been done for this particular lady, but then she wasn't passing spontaneous breathing trials, right? So a bit of a catch-22 here. So typically, though, adult patients and females in particular get a size 7 to 7.5. Adult men usually 7.5 to 8.5. I've seen 9s and 10s as well. However, a smaller tube sometimes might also be used if there are anatomical difficulties during intubation, i.e. a small airway, swelling, trauma, or vocal cord issues. The team sometimes wanting to minimize pressure on already irritated or injured vocal cords. So yes, a 6 mm tube may make ventilation less efficient and suctioning more difficult, but sometimes it's necessary to reduce trauma to the airway. So one of the issues there is that, especially when a client or patient has regular suctioning needs, i.e. their airway needs to be cleared by inserting a suction catheter into the lungs, that's when it can become tricky, right? Because depending on the volumes of the secretions, you can only get a smaller suction catheter in, right? And then you may not be able to remove the secretions you need to remove, right? So, different for pediatrics, of course, for children, but for an adult, the tube might actually be too small, depending on the size of the patient, of course. So it is just something to keep in mind. So what's the impact on intubation and extubation for a size 6 breathing tube? A smaller tube can make breathing harder, especially over time, and it may be more irritating due to a higher airflow resistance. So for example, if a patient weighs 80 kilo, right? Literature suggests and research suggests for 80 kilo patient, you should get 7 to 10 mils per breath, right? So for simplicity, 80 kilo times 10 is 800 mils per breath. Now with the size 6 breathing tube, which is a really small size, you may not get the volume in, right? Because the tube is simply too small. So there can be some real implications here, right? Also, it might make it harder to wean off the ventilator in some cases, exactly for the reasons that I just explained. But it may be less damaging to sensitive or injured vocal cords. It also makes it harder to perform bronchoscopies or deep suctioning, which might affect care if secretions build up, just as I explained a minute ago. Can vocal cords heal while intubated? Well, healing can happen, but it's limited while the tube remains in place, especially if the cuff is pressing on the area near the vocal cords. There has been repeated trauma from previous intubations. The tube stays in place for many days, usually 10 to 14 days, which is raising concerns anyway, because that is when the discussions around a tracheostomy usually start. So a tracheostomy is then often recommended to allow the vocal cords to rest and heal, reduce pressure on the larynx and trachea, make weaning from the ventilator easier, improve comfort and communication in some cases. But your mom's fear is also completely understandable, because it's important the doctors explain why they're recommending it and whether a short trial of the tube is possible before committing to a tracheostomy. So what should you be asking the intensive care team? Why was a 6 millimeter tube used, or a size 6 tube used in the first place? Was it due to anatomy or vocal cord injury or trauma or anything else? Can they assess the vocal cords with a bronchoscopy whilst she's still intubated? Is she a candidate for a trial extubation? And here's another thing. This particular lady had 2 failed trial extubations, right? So with 2 failed trial extubations, unfortunately, and with her no longer being able to pass any spontaneous breathing trials, we strongly recommend that a tracheostomy is the next step here. Not a PEG tube, just a tracheostomy. But the family also needs to ask for a weaning plan. What's the plan to wean? The good news is this lady is already doing physical therapy. She's already getting out of bed every day. She's marching on the spot even, which is fantastic. So chances that her breathing muscles will strengthen are pretty high. The biggest concern here is, as I explained earlier, is this lady potentially having sleep apnea, which would then explain why she's having high carbon dioxide. Now, also coming back, so this lady is sitting on the 10 to 14 day mark. Doing a tracheostomy is imminent, especially since she's not passing spontaneous breathing trials. The question is always, would a couple of more days make a difference, right? Sometimes they can, and then you should not proceed with the tracheostomy. But in this case, we looked at the medical records, we spoke to the doctors. It looks like the best way forward here is to do a tracheostomy, do physical therapy, get on a weaning plan, get her out of bed every day, strengthen breathing muscles, and then hopefully she can be weaned off the ventilator and then eventually have the tracheostomy removed as well. Another question you should be asking to the doctors here, what are the chances of vocal cord recovery with or without a tracheostomy, i.e. with a breathing tube or with a tracheostomy? Well, again, chances are that the vocal cords will heal much quicker with a tracheostomy as opposed with a breathing tube, because the breathing tube will be going right through the vocal cords. So you're doing the right thing, asking all these questions. Vocal cord injuries can sometimes recover, but prolonged intubation may cause further harm. This is why tracheostomies are often considered after 10 to 14 days. A tracheostomy by no means giving up. It is often a bridge to healing, better breathing, and weaning off the ventilator. Right? So, Helene, you're saying CO2 BiPAP from being intentionally prescribed incorrect known allergic medication for early stages of pneumonia. CO2 BiPAP from being intentionally prescribed incorrect known allergic medication for early stages of pneumonia. Mom's vocal cords were permanently injured from iatrogenic induced injuries from a misused and overused BiPAP machine and hospital cuffs. And that was at Star Atlanta Medical Center South. Okay. Interesting. So I can obviously not comment on whether your mum, whether the BiPAP was prescribed incorrectly, and I'm not sure, obviously can't comment on whether known allergic medication for early stages of pneumonia was happening as well. We would need to look at the medical records here. Okay. Coming back to and your mom's vocal cords were permanently injured from iatrogenic induced injuries from a misuse and overused BiPAP machine and hospital cuffs. That's very disappointing, and it's very distressing to hear, Helene, that this is what's happened. Okay, so coming back to our email there from our client. So what are the questions that you should be asking specifically about the tube size and the reasoning? So again, can you explain why a size 6 tube was used for the patient or for my mom instead of the standard size? This helps clarify if this was due to anatomy, vocal cord injury, trauma, any other concerns. Does the smaller tube increase her risk of complications or delay healing? And like I explained, with a smaller tube, volumes might be limited, right? The ability to suction secretions might be limited. The resistance is usually increased, which is not a good thing, right? And then bronchoscopies might be limited as well. And that leads to the next question you should be asking. Has anyone done a bronchoscopy or checked her vocal cords recently to assess injury or healing? If not, ask, can we request an ENT consult or a bedside bronchoscopy to evaluate the vocal cords? ENT stands for ear, nose, and throat, and those are often the specialists that need to come in a situation like that. Is it possible for her vocal cords to heal while she's still intubated, or does the tube prevent proper healing? It's also a question you should be asking, and that is more a question for ENT actually, rather than for ICU directly. Okay, then how can you avoid a tracheostomy in a situation like that, if you can? Would it be safe to give her a few more days on the tube to see if her vocal cords improve? Now, in this situation, that would be only one aspect of it all, because the other aspect of that situation is that this particular patient already failed 2 spontaneous weaning trials, right? And that would put her in the category of that the tracheostomy would be most imminent. Is she a candidate for a trial extubation, even with a small tube to test if she can breathe on her own? Again, this would be a question for someone that hadn't already failed 2 trial extubations within recent days whilst being off sedation and opiates. What signs would tell us if she's getting closer to being safely extubated without needing a tracheostomy? Clearly, one of the signs is that she's passing spontaneous breathing trials, that her tidal volumes are not dropping when she's breathing spontaneously, that her minute volumes are not dropping when she's breathing spontaneously. Her arterial blood gases are within normal range. She's not getting tachypnic, meaning her breathing rate remains normal between, let's just say, 10 to 25 breaths per minute with a normal tidal volume, normal minute volume. That FiO2, the oxygen that she's getting from the ventilator, is less than, let's just say, 35%. Room air, the air that you and I are breathing, is around 21%, right? Obviously, that she's awake and alert. And most importantly, in this situation, because this lady has been hypercapnic or had a high CO2, that CO2 is within normal range, right? So, about the tracheostomy decision, if she gets a tracheostomy, will it help her vocal cords heal better by taking pressure off that area? Most likely. Would the tracheostomy be temporary, and what are the signs that would show she can eventually have it removed? Well, clearly, the tracheostomy, the goal should always be temporary, should never be to have it permanently. There are exceptions to that rule, and a lot of our intensive care at home clients would fit into those exceptions where they need a tracheostomy lifelong often. But there are exceptions, they're not the rule. For the vast majority of patients in intensive care that need a tracheostomy, the goal should be to have the tracheostomy removed sooner than later, right? So when someone is ventilated with a tracheostomy, the first step is to wean them off the ventilator. The next step is to remove the tracheostomy. Difficult to get to talk about timelines here. And can we delay the tracheostomy decision a little bit longer, or would that increase the risk? Well, like I said, if this lady hadn't had any failed trial extubations already, I would say yes, absolutely. Hang on for a couple of more days. The difference between having a tracheostomy or not having a tracheostomy is pretty stark, let's just say. On the one hand, not doing a tracheostomy, getting off the ventilator and the breathing tube would move a patient, towards recovery pretty quickly. On the other hand, there are delays in recovery when doing a tracheostomy, but in this situation, it'll take longer not doing a tracheostomy, right? So I hope that helps answer your question. And go from there. Now, other question that's come in during the week. And by the way, if you have any questions, please type them into the chat pad or connect with me here live on the StreamYard link. Just click on the StreamYard link that I posted in the chat pad and you can talk to me directly here. Okay, I've got a question here from another reader who says, "Hi Patrick, my mother now is in ICU since yesterday morning. My brother was there to give her CPR after cardiac arrest. The ambulance came after 5 minutes and it took 20 minutes to get a pulse back. She has kidney failure and a high potassium. Her vitals are almost normal, but she hasn't woken up yet. They said if she goes into cardiac arrest while on dialysis, then they'll pull the plug." Well, that's terrible to hear. And first off, it is not up to intensive care teams to end someone's life without consent from a patient or a family, right? Let's just call it for what it is, right? Never ever believe that end-of-life decision-making is happening in a vacuum. Never ever believe that. Because that's what ICU teams often try to insinuate, that they can do whatever they want when they want, right? Always use common sense, use common reasoning, and trust your gut, right? Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is exactly what you are up against here, right? ICU teams can't just quote unquote pull the plug and end your mom's life, right? That could be a mixture of perceived murder, perceived homicide, perceived euthanasia, or a combination of all of it. It is illegal. No end-of-life decision-making happens in a vacuum. No matter what anyone tells you, right? And I can't believe how many families in intensive care believe that ICU teams can just do whatever they want. So, obviously, I'm very sorry to hear that you are going through this. So you've been facing a very challenging situation here, a very hard situation. And now your mom is in ICU after a cardiac arrest. It's heartbreaking. So based on what you've shared, here's a breakdown of the situation and some thoughts to help you navigate it. First off, let's look at the cardiac arrest. Your mom lost her pulse and was without circulation for about 20 minutes. That is a long time, and it raises concerns about possible anoxic or hypoxic brain injury from lack of oxygen. But keep in mind, your mom has only been in ICU for not even 2 days, and that is not a very long time. Keep that in mind as well. Okay, so 2 days in ICU, not a long time. You know, patients in ICU without cardiac arrest are not waking up after 2 days in ICU. So the timelines here are not very long. And again, what you need here is perspective. Most families in intensive care have no perspective of what situation they are really dealing with. Let's look at the CPR and ambulance response. Your brother starting CPR quickly may have helped preserve some brain function, but it's too soon to tell because it's only been 2 days. Next, high potassium, which is also known as hyperkalemia, and kidney failure. Those can both contribute to cardiac arrest. Dialysis is typically used to lower potassium and stabilize a patient. Vitals are almost normal. That's promising. It means her heart and blood pressure are stable for now, but not waking up yet is concerning. The other thing you need to find out is she on opiates? Is she on sedatives? Is she on anti-seizure medications, right? Have they done CT scan of the brain, an MRI scan of the brain, an EEG of the brain, right? Have they done an angiogram to check out the heart and found out what's leading to the cardiac arrest, right? Again, you don't know what you don't know in this situation, right? And you better find out soon what you don't know. But that's what I'm here to help you with, to find out what you don't know. Next, the ICU team says they'll withdraw treatment if she codes during dialysis. You phrased it as they are going to, quote unquote, pulling the plug. That is a massive red flag. You have every right to ask questions about that decision and push back if it doesn't sit right with you. Yeah, like I said, withdrawing treatment without patient or family consent could be perceived as murder, homicide, euthanasia, or a combination of all of it. Once again, I can only stress here, never ever have common sense dissuade you from what you know is right. You know that withdrawing treatment after only 2 days in ICU is completely inappropriate. You have not consented to this. I assume you are the decision maker. The first question that you need to ask here is, what's the urgency to kill someone? Where's the urgency and the rush to kill your mother? Have you thought about that? Right? And you need to push back very hard here. It is not reasonable. It is not lawful. Right? It is not lawful. Ask the hospital for the ICU end-of-life decision-making policy. There is a policy for that. Check out your state laws wherever you are. You haven't identified your location. Doesn't matter whether you're in the US, you're in the UK, Australia. Check out your local state laws, and you will find that withdrawing treatment and letting someone die without patient or family consent is illegal, right? So what questions should you be asking now? Again, neurological status. Has she had a brain scan, CT or MRI? Has she had an EEG? Are they doing neurological assessments such as pupil response, motor response, leading to Glasgow Coma Scale? What's her Glasgow Coma Scale? Kidney support plan. Are they doing continuous dialysis, also known as CRRT, or planning regular hemodialysis? What are the risks of dialysis in her current condition, and how are they preparing to manage them? Most importantly, DNR and code status. Who made the decision about quote unquote pulling the plug? If she arrests during dialysis, well, you better find out, because that person could be held personally liable. Is she currently listed as full code, DNR do not resuscitate, or DNI do not intubate? Having said that, she is intubated at the moment. Did you consent to any of it? If not, ask them to stop and take her off the DNR and explain all options before making any assumptions. What's her prognosis, and what's the monitoring like? How long are they willing to observe her for signs of neurological recovery? Are they doing an EEG and other tests to check for seizure activity or brain function? Your rights and your role. You and your family have the right to a second opinion, of course, which we can give you here at intensivecarehotline.com, especially from a neurologist and nephrologist as well. Refuse withdrawal of treatment unless you're fully informed and in agreement. Request a family meeting with all key specialists, ICU doctor, nephrologist, neurologist, cardiologist, case manager, and so forth. If you feel pressure to agree to end her life, document who said what and when, and ask for things in writing when possible. And I would escalate this very quickly to hospital executive if I was you. What should you do right now? Talk to your family and decide what your mother would want. Has she ever said anything about life support, dialysis, or resuscitation? Ask for updates every few hours. Don't wait for them to come to you. Get access to medical records so that you can check up in real time what's being done, what's potentially not being done, what are they documenting about their team meetings, and make it very clear that you are not ready by any means to withdraw treatment unless there's overwhelming and clear medical evidence or any other evidence that's what your mom would want. Right? So, Helen, you're saying Atlanta Medical Center South Hospital did not want to provide me with their end-of-life policy and procedures. Yeah, sure. Look, Helen, I can't comment on, obviously what's happened there. All I can say here is you have the right to it. And maybe you didn't know at the time that you had the right to it. Again, hospitals are very good at pretending they can do whatever they want, and they're very good at withholding information if they want to. So coming back to our email, when speaking with the ICU team, you can bring the following points into a family meeting or ask these directly to the attending doctors, ICU nurse, nephrologist, cardiologist, neurologist, or case manager. Has she had a brain or CT scan or MRI? What did it show? Is there an EEG being done to assess brain activity? What is her Glasgow Coma Scale right now? Are there any signs of purposeful movement or response to voice and touch? How long do you recommend we wait to assess possible recovery? Let's look at cardiac arrest details. How long was she without a pulse? Were there any signs of oxygen to the brain during CPR, i.e. reactive pupils, or any movement? Was therapeutic hypothermia, also known as cooling therapy, used to protect her brain? Next, kidney function and dialysis. What type of dialysis are you planning? CRRT or intermittently? What are the specific risks of doing dialysis in her condition? How high was her potassium and has it come down? What are you doing to prevent another cardiac arrest during dialysis? One of the reasons this is important is, when someone is in kidney failure and has a high potassium, high potassium can lead to cardiac arrest. On the other hand, if you start people on dialysis, potassium can come down very rapidly. And because potassium can come down very rapidly, it can also cause cardiac dysfunction, including cardiac arrest. So monitoring potassium within a certain range is very important. Next, code status and resuscitation. What is your mom's current code status, full code, DNR, etc.? Who decided that resuscitation would not be attempted during dialysis? And hold them to account. I would go as far as two things. Report it to a hospital executive, make a complaint, and you could also potentially report this staff member to their, to the medical board in your state, for example, or in your country. Has the family been asked to approve any code status being changed? And it sounds like that has not happened. So, you absolutely need to speak up there. Let them know that you never agreed to withdraw treatment without a family discussion and a full understanding of prognosis, let alone without consent from your mom. One way to approach it is you need to ask them to wait for your mom to wake up, right? Once your mom is awake, things might become clearer. Find out what the goals are for the next 24 hours, 48 hours, and 72 hours. That gives you a better indication of what they're planning. And are they doing anything beyond thinking that they might need to withdraw treatment? Get a meeting with them as quickly as possible. You would like full updates at least twice a day, and you would like to get access to the medical records immediately, and you would like to get access to the medical records online so you can look up things in real time. You should also let them know in no uncertain terms that you want to have the family included in all major decisions, especially regarding withdrawal of treatment, but any major decision needs to be made by you and by you only. What should you be talking about with your family? So you absolutely need to be unified about honoring your mother's values and not making any rush decisions. The ICU staff may present a bleak outlook early. This is common, but some patients do wake up after several days or even weeks and even months. And this is what I'm saying. 2 days in ICU talking about withdrawal of treatment is very inappropriate. It's premature. And once again, you should be asking, what's the rush and where's the urgency to kill your mom? Get an explanation there. Ask them, do they need an ICU bed? Do they not have enough staff? Do they not have enough beds? Do they not have enough resources to deal with this? Ask for more time and careful consideration and testing before discussing withdrawal of treatment. Ask them for the ICU withdrawal of treatment or end-of-life decision-making policy. I can guarantee you that it says treatment cannot be withdrawn without patient or family consent. It's about patient autonomy, right? So get a second opinion. We can give you that second opinion here at intensivecarehotline.com. Get access to the medical records. Let me talk to them. Let me talk to them. And, we have saved so many lives for our clients in intensive care in similar situations. And we've always changed these situations around. As long as you let us do the talking, or as long as you can take advice and run with it, right? So, other questions from Ina, who says, my grandma has been on the ventilator with a breathing tube for a week now, even though she was fully conscious and tried taking it out 5 days ago, but her nurses now tied her down. That sounds horrible, Ina, and I'm very sorry that you're going through this, because seeing your grandma restrained on a ventilator can be incredibly painful and confusing. If your grandma has been conscious, responsive, and trying to remove the breathing tube for 5 days, it's important to ask some critical questions. Number one, why is she still intubated? Ask the ICU team why she hasn't been transitioned to a tracheostomy if needed long-term, or weaned off the ventilator. Being awake and alert typically means she may be a candidate for extubation or at least for evaluation. Why is she restrained, and is it even legal? Restraints are often used to prevent critically ill patients in intensive care from removing medical devices, but prolonged restraints without clear communication or alternative care plans can be highly unethical, potentially illegal. Request a care conference or speak with the nurse in charge, medical director, ICU doctor, or attending physician. Is there a plan for next steps, and is there a plan to stop using the restraints? What are their criteria for extubation? Are there complications preventing it, like weak lungs, weak breathing muscles, infections, airway issues? What are the issues and what are the timelines? Most importantly, patient rights and advocacy. You or another healthcare proxy can formally request an ethics consult if you think it's appropriate, and if you think that the ethics committee is actually truly independent. Most ethics committees in hospitals are not independent. They are hospital employees, and they will side with whatever the hospital wants most of the time, because their careers are hinging on their opinions, right? If you feel like your mom's care or your grandmother's care is not progressing appropriately, consider involving advocacy, which we provide here at intensivecareoutland.com. So do never ever let the hospital get away with what I would perceive as second-class behavior. Never ever. It is completely inappropriate to do that. Right? So always go with your gut. Always go with what is what you think is right, and always go with what you justify is right for your family member. Never ever go with anything that you don't agree with, that you think is inappropriate, that you think is unethical or potentially unlawful. And never ever let ICU teams dictate to you what is right and what is wrong. You know what is right and what is wrong. You know exactly what is right and what is wrong. And do not let anyone dissuade you from what you know is right and what is wrong. Okay, so let's then quickly look at to speak with your grandmother's medical team and get the outcomes and results that you want, need, and also deserve, right? So you should say that you're very concerned because your grandma has been intubated and restrained for over a week now. And you understand she has been conscious and trying to remove the breathing tube for at least 5 days. Now, picture this. I mean, anyone that's seen their loved one being restrained in ICU know that it's not a great experience. It's like being a prisoner. Imagine you're critically ill and then someone is restraining your hands. That is not a good situation to be in, and it doesn't help with healing. Ask them to help you understand why they're doing it. Ask for medical justification. Why is she still intubated? Have they put her back on sedatives and opiates? And is there any medical reasons why she hasn't been evaluated for extubation, just as yet extubation means the removal of the breathing tube? And has she been assessed for readiness to breathe on her own? And ask about the use of restraints. Why is she still being physically restrained? Is this even legal? Show them the relevant policies, procedures, and laws. Has she been given any alternatives, such as light sedation, light opiates, soft mittens, or supervision. And I think supervision cannot be underestimated. Now, if you find ways that the nursing staff can talk to her calmly and gently and can talk her through what needs to be done from a ventilation point of view, that might avoid the restraints. Do they potentially not have enough staff? Are they understaffed? Is that why she's restrained? Clearly push for a clear plan to get her off that ventilator. Is a tracheostomy potentially necessary? Other question is what needs to happen for her to be safely extubated? And can they set a timeline and specific goals for getting off the ventilator? Right? And I would, regardless, I would really make a complaint about the restraints. Right? I do believe that is very inappropriate and it's very unethical. Right? So, I hope that helps you understand what's happening there. So, what else? The other question we had was end-of-life decision-making in Washington, D.C. So we were working with a client just a few days ago who had their partner in ICU, and again, similar situation to the email that I read out earlier, where the ICU basically wanted to make a decision, or tomorrow by 3 o'clock, we are going to withdraw treatment on your, in this instance, 36-year-old partner. Right? Think about that. ICU just says tomorrow at 3 o'clock, we're going to withdraw treatment. Now, thankfully, this lady reached out to us and said, look, this is highly inappropriate. What can I do? We advised her what to do. And, we know she put a stop to it, but this is what I'm saying. ICUs are very good at pretending that they can do whatever they want. And that's simply not accurate. Right? So, no ICU can just end someone's life without patient or family consent. Right? Never forget that. Never, ever forget that. Right? So, in Washington, D.C. in particular, individuals can create advanced care directives, including living wills and durable powers of attorney for healthcare, to outline their medical care preferences in situations where they cannot communicate their decisions. And that is exactly what, proxies or medical decision makers can do as well. Because if a patient is incapacitated, can't make decisions, then the decision-making authority moves obviously to the decision maker or proxy or medical power of attorney, next of kin, whatever you want to call it. So, Helen, you're saying that's what I called and reported iatrogenic, egregious false imprisonment and medical cruelty when mom was illegally restrained at Wellstar Atlantis Medical Center South. Yeah. Right. I bet she was severely traumatized. There's no question about that. There's no question about that. And I know, having worked in the industry for such a long time, that, ICUs are sometimes simply doing that because they don't have the staff. They don't have the staff numbers. So restraining someone is the quote unquote easy way out, whilst they're traumatizing patients and their families potentially as well. So I really hope that helps you understand more about your rights when you have a loved one critically ill in intensive care. So, one of the main questions you really need to ask when you have a loved one critically ill in intensive care. Most families that are coming to us that are watching this, they have a family member in intensive care where they are often getting told, oh, you should just remove treatment, you should just stop everything because your loved one isn't going to survive anyway, and your loved one will have no quality of life if they do survive. And what is quality of life? It is not an objective measure, it is a subjective measure, right? Quality of life is up for the individual to make the decision on, not for anybody else. You know, and it is often deeply personal, and it is very complex as well. So do not let anyone make that decision and that call for you, because it is not up to them. It is entirely up to you and your family to make that decision, right? And like I said, the number one question that I would always have for any family in ICU when ICU is trying to push for end of life: what's the rush? Where's the urgency to kill someone? You know, what's the rush? Where's the urgency to kill someone? That is the number one question. And where's the rush to cure someone, to give them the time they need? That is the much better question to ask. You know, contrast that with each other, you know. So are there any final questions before I'm going to wrap this up? I forgot to say that I usually always go for about an hour. We are reaching the hour mark in a couple of minutes, and I need to wrap this up. If you need help for intensive care hotline, if you have a family member in intensive care, I encourage you to go to intensivecarehotline.com, call us there on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. We also have a membership for families of critically ill patients in intensive care, and you can get access to the membership by going to intensivecarehotline.com, click on the membership link, or go to intensivecaresupport.org directly. I also do one-on-one consulting and advocacy over the phone, Zoom, WhatsApp, whichever medium works best for you. We do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. I also talk to doctors and nurses directly on your behalf or with you. And you know, and I ask all the questions to the doctors in particular that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. Yeah, end of life discussion is a final discussion or a final decision. And that's why I'm also saying that you should not make a decision today that you regret in 12 months' time. That would be my number one advice. Do not make any decision today that you would regret in 12 months' time, because it is a final decision, right? So, and also understand medical prognosis clearly and listen to what they have to say. And if it's too negative, if you think it's too negative, get a second opinion. Don't let the negativity drag you down, because there's always someone that has come out of it. There's always someone that's come out of it. Right? Also, if you need intensive care at home services, go to intensivecareathome.com. Again, call us on one of the numbers on the top of our website there, or send us an email to info@intensivecareathome.com. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are serving NDIS participants all around the country, TAC in Victoria, DVA all around the country as well. And obviously we're also taking on private clients. But if you're a hospital executive watching this and you have bed blocks, please reach out to us as well. I do wrap this up now here. Thank you so much everyone for watching. Like the video, subscribe to my YouTube channel, share the video with your friends and families, leave your comments below so I can create the content that you want me to create. And I will talk to you again next week at the same time. Take care for now. Wishing you all the best.